severe lesion, but there was enough head rattle in there when she got hit that it traumatized that nerve. And so even though she got him open, I'm like, I'm calling the ambulance. And you can tell them that you're not going. She did not go to the hospital. She had a severe concussion, does not remember any of it, and thankfully she didn't have any residual symptoms after that. So, no health insurance. Now, how you play football as a male or a female and have no health insurance, but then again, the men's team I covered, half of them had no insurance either. So, I had a femur fracture. And the guy threw a clot and got a pulmonary embolism, which means that basically he blocked the blood flow to part of his lungs. So he was killing lung tissue if they hadn't caught it. And you can imagine after 4 days his bill was over $50,000. And he had no health insurance. I think a bankruptcy court probably ate that one. All right, so moving on. That's my fun. So again, like if I could have had that on video, like watching her trying to like control her, no, it's cool. It's so cool. So, but I don't. All right, so trigeminal nerves. Tri means 3 branches. So we have 3 branches of the trigeminal nerve: ophthalmic, maxillary, and mandibular. All of these are sensory. And we can kind of branch them if you take your fingers across your face. So you've got the first branch is going to come up and over your forehead. Your second branch is going to be your cheekbones, and the third branch is going to follow your mandible. So if you're going to assess for the trigeminal nerve, you want to assess all 3 branches through light touch and then 2-point. So one thing you may or may not have noticed with reflex hammers is that the reason there's a blade is so you can do those kinds of things. So you can do light touch through here as well as apply deep pressure. So it exists. You can also do soft versus hard discrimination. So if you have a Q-tip and you snap off one end, then you can do a light touch from the cotton swab, and you can have the sharp touch and the rigid touch from the bottom end of it. So different ways to assess with the tools you have, because you don't always have a medical kit lying around, but you can improvise with what you can use your hands on. So ophthalmic is the top portion that goes over the forehead and down across the top of the nose. Maxillary comes in over the zygomatic arch, and then the mandibular is over the mandible, over the jawline. This also gives you the anterior 2/3 of tongue as far as sensory palpation. But we're not talking taste at this point. So we talked about adducent, which is 6. Number 7 is facial. So assessing facial, this is mostly a musculature. It's facial expressions. The stapedius of the middle ear, the stylohyo, the posterior belly, the digastric muscle, which is down and through here, through the neck. The simple one in facial is smile and frown. So we want to assess the musculature that we just saw a whole huge picture of. Can you smile for me? Can you frown for me? You're looking for equal motion on both sides. This is when as you've seen, so many muscles going on that if you've got something going on neurologically, this is also used for indications of stroke, but for different reasons. But cranial nerve 7 is going to be facial. This gives you the sense of taste on the anterior 2/3 of the tongue. So if you've got something for them to taste, bitter, sweet, sour, whatever, a piece of candy that they can then taste, then that's what you're going to do. Touch it on the front part of the tongue. Can you taste that? And then we're good to go. So cranial nerve 8, vestibulocochlear. So 2 sensations here. You have vestibular and you have cochlear. Cochlear is hearing. That's as simple as coming up behind somebody and asking them. I mean, you can, if they're responding to your voice, you can also lower your voice so not speaking so loud. And you can have them respond that yes, in fact, they're hearing you. You can be a little bit more precise in terms of having them identify which side it's on. And then you go straight behind them and you really mess them up, right? So you come off to one side, and then you go to the other side, and then you confuse them and you put it in the middle. So, but you give them the ability to assess both ears because it helps to identify one versus the other. The equilibrium part, what do you think we should do for equilibrium to assess the vestibular? Single leg balance. I mean, that's pretty simple. I mean, you could easily have, can you stand on one leg? Great. Can you hold your balance? Because if it's off, if it's damaged, they will take a nosedive into the wall. It's pretty sudden. Without that system, it's not going to work well. So glossopharyngeal. Assist in swallowing. So this is number 9. So this is controlling a lot of the musculature that come down through here, which helps the peristalsis, actually pushing the food down through your trachea. No, your esophagus. Hopefully not your trachea. That would be bad. That's called aspiration. All right, so it also gives you taste on the posterior 1/3 of your tongue, so you can go in and drop a piece of flavor on the back third of their tongue and see if they can identify that piece of candy, something sweet, probably something different than you did for the first anterior 2/3. And then cutaneous sensation, so this also works the outside of the ear. So if you do physical touch to the outside of the ear, that hits glossopharyngeal as well. Vagus. If vagus isn't working, you're dead. Pretty simple. Vagus actually travels through and down along the carotid artery, and it comes down, it interacts with the heart and pretty much every other organ in your GI tract, in your abdominal system. So if it's not working, then you're not working. But you can ask him to swallow, and that's going to help assess it more directly. So swallowing is going to hit 9 and 10. And then you can differentiate 9 with glossopharyngeal with the cutaneous sensation on the external ear. So visceral sensation from base of tongue, pharynx, larynx, trachea, bronchi, heart, esophagus, stomach, intestine, the left colic flexure. So yeah, there's a lot going on with vagus. All right, cranial nerve number 11, spinal accessory. Main actions, this is motor nerve to the sternocleidomastoid and the trapezius. So given those two muscles, how do you want to assess that? What do you think? Rhomboids? Posterior delts?
I'll pull up.
So that's latissimus dorsi and teres major. So, what do you want to do for traps and sternocleidomastoid? Shoulder shrug. Yeah. So we can pull it up, have them resist, push down. Cranial nerve 11. Pretty easy. Cranial nerve 12, hyperglossal. Motor to intrinsic and extrinsic muscles of the tongue. So we want to make sure that the tongue is functioning well. So an easy way is if you have them poke their tongue to the side of their mouth, and then you push across to see if they can resist. It's a pretty simple way to do it. It's where you're not sticking your hand in their mouth. And some people find that a little bit of an invasion of personal space. That's all 12. Yay for cranial nerves. So Dolan's lines, cranial nerves, both of those will be on the oral final. Beyond that,
Good luck.
what should we take out of the last 2 lectures where we talked about a lot of head, neck, and spine? Identifying the bones of the face matter. Dolan's lines assist with that. I think I focused there because if you're going to have an injury and you need to do assessment, you've got to know which bones to look for damage and problems. I would certainly say that the musculature on the back of the head, through sternocleidomastoids, scalenes, anterior, middle, and posterior, are going to give us a good idea of where we can address injury and problems. The 3 spinal erectors, your semispinalis, longissimus, and iliacostalis, you should know about them, where they are. Multifidus, rotatories, knowing about them, certainly that the multifidus in the lumbar spine is much, much more pronounced and has a lot to do with lumbar stability. Understanding your curvature of lordosis and kyphosis by segment of the spine is something I would pay attention to.
Part two, part three.
And if you have other questions as we go for the next 2 weeks, then next week
I think you have my number.
worth of class, then I'm pretty good there. So again, next Monday, I would strongly encourage you, for those who have come in, I've told you to kind of review upper or lower one of the two this week. I would give yourself some time to go through lower functional anatomy this weekend. So there's not a lot of new material that I'm going to cram at you for this head, neck, and spine section. So if you can go through lower this weekend, that way we can touch lower on Monday and have you ready to go for that, to where I'm helping to clean things up rather than reintroducing it for the first time since 2 months ago. And then next week and into next weekend, next follow up as much as you can into upper before we have class on Wednesday.